How do you treat scoliosis in adults over 50? Hi, I'm Dr. Chris Gubbels from ScoliCare, and in this video, I'm going to address which treatments are the most effective for adults with scoliosis. A lot of us, when we think about scoliosis in kids, people when they're younger or during teenage years. But the reality is scoliosis is actually a much bigger problem when we look at our older populations. When we look at scoliosis in adolescents or teenagers, it's only about 3 to 5% of teenagers ever get diagnosed with scoliosis. And of those that get diagnosed, it's a smaller percent that actually end up needing more aggressive treatments. However, when we look at adults, the percent of people with scoliosis is much, much larger, especially as we age. For example, when we look at people that are about 40 years of age or 40 years old, it's about 9% of the population that gets diagnosed with scoliosis. Once we hit about 60 years old, it's up to about 38% of the population. And when we get over 90, it's definitely over 50% of the population. One study even suggests that up to 68% of seniors have scoliosis. So why is this such a big problem? Well, one of the reasons this has become a really big problem in the United States is because, and all throughout the world, is the percent of people that are 60 or 65 years older has literally almost doubled in the last 50 or 60 years. This is a really great graph that actually shows how the number of people over 60 and 65 has increased. And if you look at the graph, the blue line is people over the age of 60, and then the red line is people over 65. If you look at just back in the 1970s, that was, the people over 65 was only about 10% of the population. But look more recently, especially in the last decade, you can see how that's dramatically increased. And because of that, we just have a lot more people that are older, and we know scoliosis is more prevalent in older populations. So because the number of people that are older throughout the world is increasing, treating adults or adult spine deformity adults has become a major concern in the healthcare system because it can cause major impacts on pain, disability, and really impact people's overall quality of life. So let's look at the different types of scoliosis that we actually see in adults. When we look at adults, there's different causes of scoliosis. Now, one of those is you can have people that had scoliosis when they were younger. They had idiopathic scoliosis that developed during childhood or adolescence, and they still have that curve as an adult, but a lot of times it's detected more often in adulthood because the curve starts to progress over time, and a lot of times it starts causing pain. So this is called an adolescent idiopathic scoliosis present in adult, otherwise abbreviated as ASA. So basically, it's someone that had scoliosis when they're younger. They still have that scoliosis as an adult because it never really goes away. But a lot of times in adulthood, that curve starts to progress and become a bigger problem for that adult. And then we have some scoliosis that actually develops in adulthood. These are known as de novo degenerative scoliosis. And these typically come on around the onset of menopause in women and generally in the older age, like 70 or older in adults. But this is a new scoliosis that develops in adults, and these are typically more aggressive curves, meaning they progress at a higher or more rapid rate than an idiopathic scoliosis that's present in adults. And then we can have secondary adult scoliosis, and these are scoliosis that are present in adult, but it's secondary to some other health condition. It could be secondary to a trauma that triggers scoliosis. It could be secondary to some metabolic bone disease like osteoporosis. It could be secondary to an iatrogenic condition like post-secondary surgery, possibly from a fusion where the joints above or below that fusion start to break down, decay. Or laminectomy or decompression surgery. You damage the soft tissue and you destabilize the spine, and that can lead to scoliosis. Or it could be from like a pelvic obliquity, which is an unleveling of the pelvis and sacrum, possibly after a hip replacement surgery. And then a lot of times after a hip replacement surgery, the total leg lengths are not the exact same, causing the pelvis to tilt on that shorter side. So you can have scoliosis that's secondary to some other condition that progresses and develops in adulthood. But for this talk, let's really focus on the idiopathic scoliosis present in adult, and then the adult de novo scoliosis, or the new scoliosis that actually develops in adulthood. This is a really great graph that shows how these curves progress over time. So yes, we do have some people that develop scoliosis as an infant or as a juvenile. And juvenile would be like between the ages of like 3 and 10, basically before puberty or before growth spurts start. And then we look at, curves right here during growth spurts. And these are idiopathic curves where the spine is actually growing asymmetrical. So this is where we have really rapid progression in curves during the growth spurts, especially during the first 2 years of growth spurts, during that peak growth velocity, or when the teenager or adolescent grows the fastest, it's during that first 2 years of puberty. So then after that puberty area, we don't have a lot of change in scoliosis, or the rate of curve progression really starts to slow down. And we have a really gradual progression until about 40. And then later in adulthood, these curves really progress. And then later in adulthood, this is also when we have that new or de novo scoliosis that can start to present. And when we look at adults as we age, the curves tend to snowball, progress more and more rapidly over time. Now, why do curves progress? So there's several different things we can look at that are predictors of possible curve progression. And this is really important because if we can predict the likelihood of a curve progressing, we can actually start treating the curve versus waiting till it gets really severe when it becomes much harder to manage. So what are some of the things? One is we can look at if there's a large coronal or sagittal imbalance. So a coronal imbalance is when we look at the spine from the front. And normally when we look at the spine, the lower cervical spine or the upper thoracic should be directly lined up over the sacrum or the pelvis. When that curve shifts to one side, especially if that gets over like 3 or 4 centimeters, that's a high predictor of pain, but also a predictor that the curve is likely to continue to progress and get more and more severe. We can also look at the alignment from the side, which is called sagittal vertical alignment. When we look at the spine from the side, the lower cervical, like C7, or upper thoracic around T1, should line up over the sacrum. So when we're looking at the body from the side, your lower neck and upper back should line up over your pelvis. If this shifts forward, this is called anterior sagittal balance. And if this gets greater than like 4 millimeters, that's a huge predictor for pain, but it's also a predictor of curve progression. Sometimes when people have bad posture, this starts to shift backward, and that can change the lumbar curve, which can also increase the risk of progression. So what we're really looking at is global balance, or balance within the spine. If the spine is shifted off to one side, or someone's starting to shift forward, or possibly even really far back, those are high predictors of pain and curve progression. Actually, when someone has a very large anterior sagittal balance, meaning their body's really starting to shift forward, that is the #1 predictor of pain and disability in adults. So those are huge predictors when we look at overall sagittal balance. And a lot of times in adults, when we're treating those, we are trying to balance the spine, reduce big shifts from the side or the front. Now, what are some other ones? When you have a large lateral listhesis, which is basically when one vertebrae is starting to translate or shift off the side, that tells us the spine has become unstable, the ligaments that are holding the spine together are starting to give out, and the spine is really likely to progress. That's also a high predictor of pain, is when you have a shifting of the vertebrae or a large lateral listhesis in the spine. The location of the curve makes a difference. For example, in adults, curves in the thoracic spine are less likely to progress. And that is because they're kind of protected or stabilized by the bony structure of the rib cage, clavicle, and those things. So thoracic curves are less likely to progress or progress slower than curves in the thoracolumbar or the lumbar spine. The reason for this is the curves in the thoracolumbar or lumbar spine are not protected by the rib cage. And so as gravity pushes down, they're less stable, and so those are the areas that the curves are more likely to progress. So location matters. Sacral obliquity, or if there's an unleveling of the sacrum, this could be from an anatomical short leg. It could be because the sacral bone does not form perfectly symmetrical. It could be secondary to something like a hip replacement or knee replacement surgery. But if your spine is sitting on an unlevel surface, that is likely to trigger or contribute to a lumbar or thoracolumbar curve progressing at a more rapid rate. The L5 vertebrae is not seated very well in the pelvis. Now, I'll try to explain this. If you look at this picture over here, this is an iliac crest. And normally if we draw a line straight across called the intercrescent line, that should intersect between about the L4 vertebrae. This one, it actually does intersect L5. If the L5 sits higher in the spine, it is not as stable, which is a predictor of curve progression. A way to think about this, if you have someone that's really, short and stocky and wide, they're gonna be more stable and harder to push around than someone who's really tall and thin. When the spine sits lower in the pelvis, it's more stable. If the spine sits higher in the pelvis, it's less stable, but that's a predictor of curve progression due to stability of the spine. The size of the curve. Once the curve gets beyond 30 degrees, in an idiopathic scoliosis especially, it has an increased likelihood of continuing to progress in adulthood. Once it gets beyond 50 degrees, it's pretty much a consensus it's 100% going to progress. The size of the curve is not a big predictor of curve progression in de novo scoliosis, because even smaller curves are more likely to progress in de novo scoliosis compared to an idiopathic scoliosis that's still present in adulthood. And then the other thing is the amount of rotation we have at the apex of the curve. So if we look at this curve, this is the apex, and this has a lot of rotation. Once we start to get larger rotation, that's also a predictor, especially if the rotation does not match what you would expect for the size of that curve. And one more thing that can increase the risk of progression or predict likelihood of progression is if the curve in the lumbar spine does not match the size that it should be based on the size of the pelvis. So in medical terms, we call this pelvic incidence lumbar lordosis mismatch. That's really complicated for patients, but a simple way to understand this is everyone's anatomy is a little bit different. And based on someone's pelvis and where their sacrum and the femur heads are positioned, we can predict how much lumbar curve someone should have. And if you don't have the proper lumbar curve that you should have for the anatomy, that's a predictor of a curve or scoliosis having a higher likelihood of progressing. So there's a lot of different things we consider when we look at people, and then as we age and we get older, that's probably the biggest predictor of rate of progression is age, because all these curves tend to progress at an increasingly accelerated rate as we get older. Now, when we look at treating adults, the goals for treating adults is much different than kids. When we look at adolescents or juveniles, generally we're definitely trying to stop the likelihood that curve progressing to surgery, but many times we're actually trying to reduce the size of the curve. Also, adolescents a lot of times don't have pain, or if they have pain, it's generally very mild. You can have a really big curve in an adolescent with no pain at all. But in adults, the big driver tends to be pain. Adults generally present because their curve is causing pain, it's impacting their quality of life, it's impacting what we call their ADLs or activities of daily living. What that means is it's becoming more and more challenging for you to do the things that you want to be able to do in everyday life. A lot of times then adults will report increased pain with prolonged sitting, sometimes even sitting more than a few minutes. It can become unbearable. They may have increased pain for standing for long periods of time. They may get numbness, tingling, and cramping in their legs when they're walking. That's called claudication. It could be a loss of balance, but basically adults report that their pain is starting to interfere with their quality of life, and they're not able to keep doing the things that they want to be able to do. And then probably one more thing that is a concern for adults is how they look aesthetically. This is also a big concern for teenagers, but a lot of times adults start to become aware that they're starting to hunch over, they're starting to tilt to the side, and they don't want to get that, that hunched over posture, and they don't like how that looks, or we can call that like a nursing home posture. So appearance can also be a motivating factor. But when we're treating adults, the goal is not generally to straighten the spine or reduce the curves. The number one priority in adults is to 1, decrease or eliminate pain. 2, stop or dramatically slow the rate of curve progression. We want to change the natural history of curve progression in adults. And then along with both of those is improve ADLs or increase activities of daily living, which means we want to help people do the things that are important to them, whether it's simple things like being able to sit or stand and walk without pain, or possibly getting back to be more physically active, especially as people get older and they're starting to retire and they want to enjoy their lives. We want to help people keep their independence and do the things that are most important and most enjoyable to them as long as possible. And then the last thing is improving aesthetics. Now, with that being said, sometimes in adults we can reduce the size of the curve, especially in younger adults that are more flexible. They have a higher likelihood of potentially reducing the size of the curve. In older adults, as the curve gets more stiff and gets more rigid, reducing the size of the curve is more challenging. But a lot of time in adults that are older, we're still trying to improve what we call balance, which is if you're leaning to one side, that coronal balance I talked about earlier, we like to try and bring that back to midline. And if someone is really starting to lean forward, we like to bring that back into midline. So although in older adults may not be trying to reduce the actual size of the curve when measured on x-ray, a lot of times we are trying to improve overall balance of the spine, which is a little bit different than alignment. Now, a lot of people get really hung up on the size of the curve when measured on the x-ray. We measure the curves using something called Cobb angle of measurement. But try to understand that when you're looking at an x-ray, scoliosis is a three-dimensional deformity. It's a three-dimensional condition. And you're looking at a three-dimensional thing or a condition on two-dimensional views. So x-rays is just one piece of the puzzle. We also look at how the body appears on the outside, because a lot of times you'll get bigger changes in how the body physically appears on the outside, both with posture and in reduction of that rib humping that you frequently see. You may notice bigger changes on those physical appearances than you do the x-rays. So we do look at the x-rays over time, but we also want to look at how the outside looks, both in posture and in rotation, and especially when you're looking at rotation when someone's bending over, doing what's known as the Adams Ford bending test. You're basically looking at rib humping or the amount of rotation of spine. So we also have to look at that when we're looking at appearances and evaluating the overall progression and potential improvement or reduction in scoliosis. So let's look at which treatments work and which ones don't. So first of all, things like general chiropractic, general physical therapy, massage, yoga, acupuncture, Pilates, these kind of things, rolfing. These kind of things, they can be good for you. They can help decrease pain. They may help to increase mobility in the spine, but on their own, they can't really do anything to slow the progression of a curve or reduce the size of the curve. Sometimes these things are used in conjunction with scoliosis-specific treatments to help decrease pain, so they can be very palliative, and they can also help increase some mobility. So they can have a role in scoliosis treatment, but really on their own, they're not going to do anything to change the natural progression of scoliosis. So what do we know actually works? We have one, scoliosis-specific exercise or rehabilitation. Now, what exactly is scoliosis-specific exercise or rehabilitation? And how is it different than traditional physical therapy? So there's four main criteria for something to be considered a scoliosis-specific exercise. One, we have to teach the patient how to put their body in a three-dimensional correct position. So we call this auto-correction. So basically we teach the patients how to take their spine and put it in a more correct or better alignment and spinal balance. Two, we have to incorporate strengthening and stabilizing exercises in correction. So once the patient learns to put themselves in a correct position, then we have to strengthen and stabilize the spine in a correct position. Three, we have to incorporate activities of daily living, meaning we have to teach the patient how to do things they already do in their everyday life while holding their body in a more correct position. This could be simple things like brushing your teeth, going from sitting to standing, holding yourself in a correct position while you're sitting or while you're walking, and it can get really advanced to holding yourself in a more correct position while you're doing things like actually doing some kind of exercise routine. But that's the third thing. And the fourth thing is education, because the patients have to be very well educated and understand their condition to understand how to be actively involved in the proper treatment. So let's take a look at a couple studies. This is a really great study. They looked at a population of patients that were doing scoliosis-specific rehabilitation. And they looked at them over at least a minimum of 2-year time frame. And they had a really good outcome. And what they found was after an average of 2 years of treatment, that 68% of the patients experience improvement in their scoliosis. That's phenomenal. So we know these things can be really effective when done properly. But you can't just go to a provider that's had some training. The skill level of the practitioner and understanding how to implement the right exercise program for each patient is really, really critical. But scoliosis-specific exercise. At ScoliCare, we use something called ScoliBalance. ScoliBalance actually combines a few different methods of scoliosis-specific exercise. It combines things like Schroth, scientific exercise approach, chiropractic biophysics, side shift method, those things. So we actually understand that a lot of different methods have some great aspects to them, but they're not always the most appropriate for each patient. So we look at each patient and we pull from the various rehab methods out there and apply the most appropriate for each individual patient, and that helps us get a better result and a lot of times in less time as well. This is a great graph that comes from that paper I was just talking about, and this is the black line over here. This is pre-treatment, and you can see the slope, which is the rate of curve progression over time. And then right here in the dotted line is when they started doing scoliosis-specific exercises. And you can see the rate of curve progression either dramatically decreases, But in many of those cases where you see it declining, that means there was actually a decrease in the size of the curve in many of those cases. Now, what about bracing in adults? Bracing in adults could be really foreign, especially to a lot of healthcare providers, because when we're trying to brace or when we're bracing adults, the goal is different. As mentioned earlier, we're not always trying to reduce the size of the curve. Many times we're trying to stabilize the spine, we're trying to bring the spine back into balance, we're trying to reduce pain and enhance quality of life. But this is a really great study here. This is a retrospective study done looking at a group of adults with either an adolescent idiopathic scoliosis present in adults or a de novo or new scoliosis that starts in adults. And what's really cool about this paper is they looked at patients over the first 10 years. And over the first 10 years, the patients had no treatment. They had no prior surgeries, they had a history of curve progression, and they had no treatment over 10 years. And the average curve with no treatment over 10 years got about 1.28 degrees worse per year. Now, the idiopathic scoliosis actually progressed at a slower rate, and the degenerative scoliosis actually progressed at about 1.5 degrees per year. So what they found is if you had a degenerative de novo scoliosis in adulthood, over a 10-year period, on average, that got about 15 degrees worse. That's a big deal. And then these patients, they all start wearing custom braces for a minimum of 6 hours. And this is an example of what these braces look like. A lot of times they're a lower profile brace. But they started wearing these braces about 6 hours over the next 5 years. And over the next 5 years, the average patient's curve only got about 1 degree worse per year, or about 0.24 degrees worse. So think about that. We went from 10 years progressing 15 degrees to only progressing about 1 year over the next 5 years, wearing a brace at a minimum of 6 hours a day. So we know we can dramatically affect the natural progression of degenerative scoliosis by using custom braces part-time, which is different than in kids. And not only do we reduce or change the progression of curves, many people's curves even reduced, and many people actually had a huge reduction in just the levels of pain and frequency of pain. So this is that same study, and over here, these are degenerative curves. The black line is again how fast the curves were progressing. So you can see these curves are progressing at a really big rate. These over here are the idiopathic curves, which progress more linear or at a steady rate. And then right there where it turns from dark black to light gray is when they started wearing a brace. And you can see either one, a dramatic decrease in the rate of progression, but in many cases where it reverses and it goes down, it's because the size of the curve started reducing wearing those braces. So a great paper showing the effectiveness of wearing braces part-time. But then what about when we combine bracing and exercise? So awesome paper where they're looking at, or study where they looked at doing bracing immediately after scoliosis-specific exercise. And the reason this is so great is when you're doing intensive exercise, like a treatment for about 50 minutes, the spine gets more loose, it gets more mobile. So if you do those exercises and immediately after you put on a brace, you're able to capture the increased mobility from doing the rehab. Plus, the body's already starting to hold itself in a more correct position after doing the exercise. When you put the brace on, you actually start to stabilize that. And they had some really outstanding results. They found that 68% of the patients that wore bracing after scoliosis-specific rehab had no pain at all, like zero pain at all. And all of these patients had pain before doing the treatment. 67% had improvements in posture or their physical appearance. 53% had a reduction in the size of their curve by anywhere from 9 to 23%. So we know these were really effective. And what the authors concluded is we know that custom bracing can be effective on its own. But when we combine bracing with scoliosis-specific exercise, that by far gets the best result. So just a quick recap. We know that scoliosis in adults is much more common or much more prevalent than scoliosis in adolescents. We also know that this is becoming a bigger concern because the percent of our population over the age of 65 is dramatically increasing, especially as we get more and more baby boomers into that golden age beyond 65 years old. And how we treat the curve and why we treat it is different than adolescents. In adults, we're trying to decrease pain, stop progression, and help people live a normal life as long as possible. And then how we go about that, there's some of the same treatment methods, bracing and exercise, as we would treat adults, but how we approach this is different. We design the braces different in adults, and we wear the braces a different number of hours in adulthood compared to adolescents. So We know there's a lot of things that can help with adults with scoliosis, and when the curves get severe enough, surgery may be an option. But for people that utterly refuse surgery or are not a good candidate for surgery, for example, someone with severe osteoporosis or other health problems, has other increased comorbidities who may not be a good candidate for surgery, then custom bracing or scoliosis-specific rehab can be a viable option. So if you're out there and you're watching this, and especially if you're an adult and you have scoliosis and you've been searching for different treatment options, or maybe you know someone suffering from scoliosis, click on the link below and request a free discovery call. That discovery call gives you a chance to talk to me about your case, where we can review your case, we can review the likelihood of progression, and we can let you know what treatment options may be available to you. And then lastly, if you like this video content, be sure to give us a thumbs up and hit that subscribe button below so you can be notified when we release new content on treating scoliosis and hyperkyphosis without surgery. Now, in our next video, I'm going to go into detail about how we stop scoliosis progression in adults. So click on the next video and I'll see you there.